I'm going to talk about proximal realignment, soft tissue procedures that we use to realign the maltracking. So patellar tracking is nothing but a dynamic relationship between the patella and the trochlea. And maltracking is imbalance which most commonly occurs because of anatomic morphologic abnormalities, most commonly in young females. The symptom complex starts from anterior knee pain, and at the other end of the spectrum, we have acute or recurrent patellar dislocation. So what happens? If there is chronic maltracking, there is patellofemoral condyle damage and finally leads to osteoarthritis. Biomechanics we have to understand most important is the patella engages the trochlea only at 30 degrees of flexion. Patella stability is decided by osseous and soft tissue structures, mainly the trochlea, tibial tuberosity, and soft tissue can further be divided into transverse and longitudinal. Transverse being medial lateral retinaculum, the vastus medialis lateralis, the IT band, the medial patellofemoral ligament, and the newly known medial quadriceps tendon femoral ligament as well. So as I said, clinically, patellofemoral maltracking can present as simple anterior knee pain, and the other end of the spectrum will be lateral patellar instability. Acute traumatic instability is most commonly seen in the second and third decade. It commonly occurs in an extended knee where the tibia goes into external rotation, so the tibial tuberosity is pushed laterally, or it can occur because of direct impact to the patella. Most of the time it relocates again. They usually have associated MPFL injuries, menisci and osteochondral fractures, and acute traumatic instability has a 15 to 45% chance of developing into a recurrent patellar instability. Clinically, these patients are going to come to us with effusion or hemarthrosis. They usually have tenderness along the medial side of the patella and patellar facet because of condyle injury. These patients usually have a J sign. So you can see in the top video, as the patient extends and the patella goes outside the trochlea, the vastus lateralis pulls it laterally, creating the inverted J sign. There are some simple tests. We can check an increased lateral glide more than 2, a decreased medial glide less than 2, and a grind test positive shows that the lateral side is tight and the medial side is loose. Q angle has already been discussed by Dr. Sandeep very well. A lot of radiological parameters I am not going to talk in this because we already discussed this. Treatment strategies, the aim is to get a stable, functional, pain-free knee to avoid any future OA. Non-operative management is always tried for a first-time dislocator without any loose body, but the patient has to be explained there is a 30% chance of recurrence. Surgically, there are soft tissue procedures and bony procedures. Soft tissue procedures basically repair, tighten, or reconstruct. As an isolated procedure, they can be used in recurrent instability only if there is no bony malalignment, namely no patella alta, the TTTTC is less than 15, and there is no trochlear dysplasia. Soft tissue procedures can also be used, or in fact are always used in conjunction with any bony procedure. So now these can be divided into lateral sided and medial sided. Lateral sided we have the lateral release and now the lateral lengthening. And medial sided we have plication, MPFL repair, MPFL reconstruction, and now the medial quadriceps tendon to femoral ligament reconstruction. So now we'll start with lateral sided soft tissue procedures. As an isolated procedure, this is used only for lateral retinacular tightness or a lateral hypercompression syndrome, and these are diagnosed when the patellar glide laterally is less than 1, and we cannot evert the patella laterally more than about 10 degrees. Commonly used an adjunct procedure in patellofemoral instability, and kindly note that these lateral sided procedures are contraindicated as an isolated procedure when we are using it in instability. Lateral release, very well described in 1981, can be done open as you can see. The entire vastus lateralis, the lateral retinaculum, is separated from the rectus, the patella, and the tibial and the patellar tendon. It can be done arthroscopically from within the joint. A radiofrequency device is used to serially release the lateral retinaculum next to the patella from within the joint. Whether we do it open, mini-open, or arthroscopic, the results are same. The problem is it causes iatrogenic medial patellar instability because the medial structures are going to pull it off medially. There is always a possibility of over-release, injury to the vastus lateralis, and injury to the lateral genicular arteries causing hematomas. Now what we do is lateral retinaculum lengthening, or the LRL. So we differentially release and repair the superficial and the deep layer. The advantage of lateral lengthening over lateral release, it always reduces the lateral tension, but it maintains the lateral structural support, and it shows better functional outcome with respect to return to sports. Coming to medial sided procedures, We started with medial plication or medial reefing, and it can be done open as so. So this was a case of habitual patellar dislocation. We finished the lateral release, removed a slice of the medial retinaculum, and repaired the medial retinaculum again. And this is the final product where we've done a lateral release and a medial plication. It is less invasive, the arthroscopic procedure. We can always also advance the VMO, and no soft tissue grafts are needed. But the problem is it doesn't directly address the medial deficiency. It cannot work when the MPFL tears from the femoral side, and the femoral tear of the MPFL is the most common in an acute dislocation. It depends on soft tissue contracture, because if the sutures cut through, the medial plication gives way. A redislocation rate after medial plication is almost 9% compared to 2% following an MPFL reconstruction, and return to sports is almost 40% compared to 80% in an MPFL reconstruction. So coming to the medial-sided medial patellofemoral ligament reconstruction, we have to understand that this is the main constraint or restraint from the medial side, 50 to 60%. The only thing which holds the patella before 30 degrees or before it engages in the trochlea is the MPFL, and it is torn in most of the dislocation, and hence it's the essential lesion when we see a patient with an acute or a recurrent patellar dislocation. Femoral sided tears are most common, and thus a medial plication or reefing may not always help when it tears from the femoral side. Redislocation rate is only about 2%, and return to sports is almost 80% after an MPFL reconstruction. It is the most common soft tissue procedure used. The issues that we come across when we are doing an MPFL reconstruction are the graft choices, tunnel positioning, what tension should we fix the MPFL, and the fixation options. Graft choices are hamstrings, quadricep, synthetic, and even adductor magnus stenodesis. However, most commonly the hamstrings are used simply because they are easy to harvest. VS surgeons are more familiar, adequate length, and gives us adequate strength. With respect to the tunnel position, the position of the MPFL on the patella is very straightforward, usually upper and middle 1/3. The problem occurs on the femoral side. So the MPFL inserts not as a point but as an area in relationship to the medial epicondyle, the adductor tubercle, and the gastroc tubercle. And hence it is always problematic to get the anatomic or the non-isometric anatomic point of the femoral insertion. So what we use is the Schlotes point. A line extending along the posterior femoral cortex is extended distally. Where the medial femoral condyle intersects this line is line 2, and the posterior aspect of the Blumenschatz line is line 3. So the femoral point of the MPFL is anterior to the posterior cortex of the femur and in between line 2 and 3. And this can be very easily done intraoperatively using a radiograph in a true lateral position. And this is also shown to be the most accurate positioning of the femoral insertion of the medial patellofemoral ligament. Implants, we can use interference screws, suture anchors. Usually we may use 2 tunnels in the patella, femur usually has 1. Tensioning should be done in extension because we know that MPFL works before 30 degrees, so 0 to 30 degrees. Now a lot of discussion has started occurring about the medial quadricep tendon to femoral ligament reconstruction. Described in 2013, like the MPFL extends from adductor tubercle to the upper part of the patella, the medial quadricep tendon extends from just anterior to the adductor tubercle and inserts into the distalmost aspect of the rectus tendon. So the advantage of MQFL over MPFL is that we don't need to drill any tunnels in the patella. There are no implants in the patella. Hence, the risk of an iatrogenic patellar fracture is ruled out. To conclude, it is very important to identify the abnormal morphological parameter when we are looking at a case of patellar mat tracking. Proximal realignment alone will work only if the bony parameters are normal and in combination with any abnormal bony procedure if that is done at the same time too. Isolated lateral release is not used for instability anymore, and MPFL reconstruction is currently the most commonly used procedure. Thank you.